All right, very good. Good morning. Thank you very much for joining today's CCRN review. This is cardiac session 3. The links for the prior 2 sessions have been sent. I hope to everybody. I'm not sure. People keep joining and asking to be in the course. So somehow my list now is about 140 people, but there might be some repeats. So sorry if you get double billing. Today, we're going to go kind of quickly because we still have a lot that we want to cover. We're just going to hit the highlights. And remember, we're building on everything that we've already learned. So that's going to be really, really important for us to appreciate and understand. So today, I'm going to start with cardiomyopathy, which is basically an extension, either a precursor or a caused by heart failure. And we're going to talk about a couple different types of cardiomyopathies. I'm going to try to make it as simple as I possibly can. Simple is not my middle name. So those of you who know me know that I like to talk a lot and I really want you to understand. So there are a couple different types of cardiomyopathies, and those cardiomyopathies, let me just squeeze that out. I am. That's why I said recording started. Okay. All right. So I'm trying to get rid of this little visual, but I guess it's okay. No, I just don't remember how to make it even smaller. So, okay, we'll just leave it down there. All right, guys. So when we look at cardiomyopathies, there are multiple types. Dilated, hypertrophic, and constrictive or restrictive, the same kind of thing. But what's most common for us is dilated cardiomyopathy. So that's the one most likely that you'll be asked questions about. Now, what you can see with dilated cardiomyopathy is the intraventricular chamber is really large. And basically, this is failure to eject. So when we do a echocardiogram, what you'll see is HF, REF, heart failure, reduced ejection fraction. So that's quite different than what we look at with someone who has hypertrophic. Hypertrophic typically has a preserved ejection fraction, but has failure to fill. So as we look at dilated cardiomyopathy, remember that's the most common form. And here you see on the echo, here's the diameter of the LV. This is a different view, obviously, but this is a normal LV size. And here is a really large LV. Now, what's really important to remember is that in dilated cardiomyopathy, you will see that because the intraventricular chamber is large, you will regurgitate through the mitral valve. So very commonly with dilated cardiomyopathy, you will have mitral regurgitation. Looks a lot like basic heart failure because it is basic heart failure, right? It's a form of heart failure. So most common in dilated cardiomyopathy is that all 4 chambers are dilated. You have a lot of blood that sits in the ventricle that doesn't get ejected because this is a failure to eject. Dilated cardiomyopathy, failure to eject. So the EF is going to be low and blood will sit in the LV chamber and that will promote thrombus formation. Okay, so when we think about it as a failure to eject, it would make perfect sense to say what we want to do is reduce the dilation of the chamber by using diuretics, by using ACE inhibitors. And what we also are going to consider is promoting ejection using inotropes, dilating the arteries. So if I dilate my arteries and I use an inotrope, I reduce the volume load in the ventricle, I'm going to promote a better ejection. So when you have dilated cardiomyopathy, remember that is the most common form. What your goal is to promote ejection. So you're going to promote contractility and you're going to want to reduce the volume load to the ventricles. Now, if you look down at this picture right here, what you're seeing is that as that chamber enlarges, the valve leaflets get pulled apart. And that's why you see mitral regurgitation with dilated cardiomyopathy. Also, remember that dilated cardiomyopathy is a form of heart failure. Now let's look at hypertrophic cardiomyopathy, also a form of heart failure. So this is kind of the underscoring or the underpinning of heart failure when we look at cardiomyopathy. Hypertrophic means that the wall is really large. So if you're looking at this visual, you see that the LV wall is really, really large and the internal chamber is small. Now remember, you have failure to eject, but you also have failure to fill. The walls here are rigid. They're very tough. And we evaluate this hypertrophic cardiomyopathy as a failure to fill. It's also called diastolic dysfunction, failure to fill the ventricle because the chamber, which normally is quite large, is now really, really small because the muscle has hypertrophy. So that's going to be a really important concept as we evaluate and look at our patients and we think about those manifestations. Again, if you take a look at this of course is post-mortem, looking at a heart slice. You can see the internal chamber of that left ventricle is huge. So the LA, actually the left atria gets larger as well, usually gets dilated and volume overloaded, but this huge wall in the LV and the narrowing of the chamber. So these patients look very much like anybody with diastolic dysfunction. Volume sits in the pulmonary bed, extravasates out of the pulmonary vessels into the interstitium. Patient is short of breath. He's very, he may have to sleep on 2 or 3 pillows. He has very severe fatigue and oftentimes will have chest pain. Now, very common again here is to see mitral regurgitation. So you see mitral regurg with dilated cardiomyopathy, you see mitral regurg with hypertrophic cardiomyopathy, but frequently what you're going to see with hypertrophic cardiomyopathy is a history of hypertension, a history of aortic stenosis. So if my LV is ejecting against a vasoconstricted bed, it obviously has to develop its muscle, right? Because it's ejecting against a vasoconstricted bed. Also, if the aortic valve is stenosed, instead of opening easily, it's narrow, the LV has to work harder to eject. Okay? And because it works harder to eject, it will develop more muscle tone. And that's what you're seeing in this visual is that hypertrophic cardiomyopathy. So in general, with hypertrophic cardiomyopathy, as long as the patient is relaxed, sitting, resting, cardiac output is usually normal. The filling pressures go up. So filling pressures are the pressures that we measure in the vein. Remember CVP, okay, and normal CVP is 2 to 8. And wedge pressure, normal wedge pressure is 8 to 12. So those pressures are going to go up. Those pressures are going to go up because with hypertrophic cardiomyopathy, you have failure to fill, which means volume stays in the veins. And that makes the venous pressures, CVP for the right heart, wedge pressure for the left heart, it makes those pressures go up. It's just a natural evolution. Understanding that it's very hard to fill that ventricle. Okay. So medical management of hypertrophic cardiomyopathy, you are trying to promote relaxation of the ventricle. So you'll use a beta blocker. Remember, beta stim is what increases the myocardial contraction. So we're going to block beta. We're going to block calcium because calcium is necessary for contraction. So what we're trying to do is to reduce the effect of the hypertrophied ventricle and promote relaxation. If I can promote relaxation, I'm going to have better filling. We are never going to give somebody with hypertrophic cardiomyopathy. I shouldn't say never because Things may happen, but in general, with hypertrophic cardiomyopathy, we're not going to use any inotropes because they already have a hyperfunction, right? They've already got a hypercontractile function. They just have a very narrow diameter. That's why I want to promote relaxation and make the diameter bigger so I can fill the ventricle more easily. And you have to be very, very careful with these patients, giving them nitrates. Why? Because nitrates promote venodilation. So if I promote venodilation, I might reduce the venous pressure, but I'm also going to reduce the gradient that fills the ventricle. Because the venous pressure is a reflection of how hard it is to fill the ventricle. So when I use a nitrate and I dilate the vein, I now no longer am filling my ventricle. Same thing with diuresis. That with diuresis, especially if you're using loop diuretic Lasix, you're going to have pulmonary venodilation. You're going to have systemic venodilation, and you're going to be trying to promote water wasting, but you didn't fix the relaxation of the ventricle. You've got to promote relaxation of the ventricle. So that's why really beta block, calcium channel antagonists are typically what you're going to want to do. Now, if the problem is aortic stenosis, your patient is going to need a valve replacement. If it's causing severe hypertrophic cardiomyopathy, your patient is probably going to need a valve replacement. Okay, so that's how we're going to minimize that obstruction of the outflow tract. That's the aorta. I'm going to promote repair of the valve. If the problem is hypertension, I have to control the hypertension. So lots of times you'll see patients with history of hypertension who come in, they're having acute shortness of breath and chest pain. We do an echocardiogram. We see that the wall is really large and the diameter of the ventricle is really, really small. Because the diameter of the ventricle is small, the volume is stayed in the veins. That's why they have venoedema, pulmonary edema, systemic edema. And with hypertension, the very first goal will be to reduce the venoconstriction. So again, if you're using beta block, you're using calcium channel antagonist, you may use ACE inhibition, but you've got to be careful with ACE inhibition because that's going to promote a higher water load. So ACE inhibition may be an agent that you're using for hypertension management, probably isn't going to be a primary agent if your patient is actually in heart failure related to hypertrophic cardiomyopathy. And ultimately, the issue is that your heart is failing. So ultimately, as you move along the stages of heart failure that we talked about last week, so stage 1 through stage 4, as you move to stage 3 to 4, the consideration will be heart transplant. Okay, now restrictive cardiomyopathy is a little less common. Restrictive cardiomyopathy means that your ventricular wall is rigid, not necessarily hypertrophy, but it's not particularly distendable. So contractility is generally unimpaired. It's the least common form. And again, the only way to diagnose the different types of cardiomyopathy is with an echocardiogram. You can't diagnose it by EKG. Got to have an echocardiogram. We're going to look at the chamber size. We're going to look at the size of the wall. We're going to look at the wall that separates the right and left heart. That's the septum. And we're going to look at the valves. That's what the echo does for you. These patients need echoes emergently, immediately, but they don't really have time to wait 24, 36, 48 hours. They are going down the tubes, and we really have to diagnose what the problem is. And remember, they either have a preserved ejection fraction or they have a reduced ejection fraction, right? So PEF means preserved ejection fraction. REF means reduced ejection fraction. So when you're reading your cardiology note, you might not be looking at the echocardiogram report, a lot of numbers, a lot of information, things about outflow tract, all really important. But what you're really wanting to know when you look at an echocardiogram, do they have preserved ejection fraction or do they have reduced ejection fraction? Reduced ejection fraction means systolic dysfunction. Preserved ejection fraction usually means diastolic dysfunction. And at some point, they become coexistent. So at some point, when we haven't treated patients, they're going to have both failure to fill and failure to eject. So that's really what happens ultimately. So when you're looking at an echo report, that's the first thing you want to know. The second thing you want to know is the state of the valves. Do I have aortic stenosis or regurg, mitral stenosis or regurg, and typically tricuspid stenosis or regurg? That's what you're looking at when you look at an echo. Now, no one's going to give you an echo report and ask you to interpret it, but you will have things that say HF, REF. Heart failure, reduced ejection fraction. Okay, so when you have reduced ejection fraction, your primary problem is failure to eject. Good? Okay, fantastic. All right, so with restrictive cardiomyopathy, it looks just totally like hypertrophic cardiomyopathy, right? Patient has shortness of breath, they're really tired, they might have chest pain, they're in heart failure. And that's because the wall is stiff, not necessarily hypertrophied. So the diameter of the ventricular chamber is normal. But what we see is that they don't distend. And so again, you have to have an echo to tell this. So again, no one's going to ask you to diagnose an echocardiogram on your exam, but you have to be able to interpret this in your clinical practice and interpret the information. So if they're guiding you to an answer for diastolic or systolic dysfunction, they're going to say your EF is low, it's less than 50%, but you don't have any pulmonary edema, you don't have any systemic edema. So that is primary systolic dysfunction, right? So your EF is low, but you don't have venous engorgement, you're going to give an inotrope. You're going to want to give an inotrope if the patient is critical. Okay. All right. So with restrictive cardiomyopathy, makes perfect sense, right? This is really about a failure to fill. So you're going to see high filling pressures. The response will be arterial constriction, which then in turn decreases your cardiac output. It looks just like regular heart failure. It's the least common form of heart failure or cardiomyopathy. And remember, cardiomyopathies actually contribute to heart failure. So that's really, really important. So again, it looks very similar to what we talked about before, except now I'm going to give inotropes plus diuretics, plus vasodilators, plus ACE inhibition, and I've got to control the process of dysrhythmia, because that's going to be a really significant issue. Typically, what we're going to do with these patients, we're going to treat them like they have heart failure. Typically, if they've got any kind of obstruction, we may do some alcohol ablation, but most common, that's not really very common anymore. Most commonly, we're going to try to manage them medically and consider them for heart transplantation. All right, so we're going to move from that to valvular disease, reminding ourselves that we're talking about two groups of valves. The AV valves, which separate the atria from the ventricle, and the semilunar valves, which separate the ventricles from the arteries. Okay, so really, really, really important for us to remember this when we think about the valves. The S1 heart sound, S1 heart sound is the beginning of systole, and S2 is the end of systole and the beginning of diastole. Okay, no, you're not going to be listening to heart sounds on your exam, but it's going to be described as systolic or diastolic. So everybody expects that you know normal heart sound S1, S2. I found that sometimes people don't really understand. S1, beginning of systole. So what's happening during systole? You're ejecting, okay? So semilunar valves are open, AV valves are closed. S1, semilunar valves open, AV valves closed. S1. S2 is the end of systole and the beginning of diastole. So AV valves open, semilunar valves closed. Okay, really, really important. In fact, so important that I'm going to just put that right here if I can. Sometimes that doesn't allow me to manipulate. Okay, yeah, not going to allow me to manipulate, but a really important concept because they don't actually have PowerPoint loaded on this computer. Okay, so really, really important to remember. S1, the beginning of systole. AV valves closed. That means mitral and tricuspid should be closed. S2, S1, mitral and tricuspid closed, aortic and pulmonic open. Good? Okay. S2 is the beginning of diastole. What can I say? There's a ghost in the system. So I have to wait for it to stop all the way so I can repower up and get it back up. But we're okay. I'm just going to keep talking because you knew what that slide was. People in virtual still have the slide. Other folks aren't seeing that slide, but it's okay. So I just want to remind you that, again, you're not actually going to be listening to someone's heart. So the description will be, you have a systolic humming murmur. A humming murmur describes stenosis. Okay, so if it is a systolic humming murmur, that describes stenosis. Stenosis occurs when you're thinking about that correlation in the valves that should have been open. So what valves are you looking at for the possibility of stenosis? If it's a systolic humming murmur. Pardon me? Your semilunar, and most likely it's going to be aortic. It's a little unusual to see pulmonic stenosis. So, and especially on exam, they want to ask you about aortic stenosis. Okay, so that's a really important concept. Okay, so if the murmur is a systolic murmur that is blowing or whooshing, that describes regurgitation. So regurgitation occurs with valves that are supposed to be closed, correct? So if the valves are supposed to be closed, what valves would that be? If it's systolic. AV, so either mitral or tricuspid. Okay, so understanding S1 is beginning of systole. No one's going to ask you what valves make the sound, right? S1 and S2, the assumption is your critical care nurses, you know what S1 and S2 are, but you've got to understand the description of systolic murmurs. Humming, stenosis, and that's on a test. Blowing, regurgitation. And the same will be true for diastole. If you've got a humming murmur on diastole, and often what happens is at the beginning of diastole, it'll be the loudest, and then it will decrease. So we call that decrescendo. You've got a humming murmur on diastole. Humming murmurs, stenotic murmurs, are murmurs heard with valves that should have been open. So during diastole, what valve should be open? AV valves, because you're filling your ventricle. Excellent. So here's what I'm saying to you. Read the question. You're not going to listen. They're not playing heart sounds for you. And they're going to try to make it as simple as possible, not complex. There's a lot of complexity to valvular disturbances, a lot. They're not going to try to get it complex, asking simple questions. Okay, well, if I have a murmur of stenosis during systole, and a murmur of regurgitation At the same time, which you can see, you have most likely, and your lungs are wet, you most likely have aortic stenosis and mitral regurg, which is very common to see in patients with hypertrophic disease. Very common to see. So really, really important. Okay. So remember, stenosis, the valve opening decreases in size, the leaflets don't open, and the chamber in front of that valve, so the ventricle in front of that stenotic valve, will actually hypertrophy. As the valve hypertrophies, or as the as the ventricle hypertrophies, or as the ventricular chamber dilates, you'll start to see regurgitation. Okay, now obviously you can see direct injury to the valve. That can come from endocarditis, it can come from an MI, but here we're really looking at valvular disease as it relates to heart failure. So mitral stenosis, often what you'll see is MS and aortic regurg. Those are typically seen during diastole, and mitral regurg plus aortic stenosis you see during systole, right? So that's kind of Ms. Ard and Mr. Ass. That comes from Nicole Kupchak. She gives all these funny names. I'm not sure they really help anybody, but I think it's always really, really important to remind yourself that the focus here is really going to be on the left heart. It's not going to be on the right heart in your exam. So a diastolic murmur, that's stenotic, which is humming, is typically going to be mitral stenosis. Blowing is going to be aortic regurg. Okay. Good. All right. So lots of things that cause these problems. And remember, the major focus for us on our exam is evaluation of the aortic valve and the mitral valve and how that affects left ventricular function. So lots of different things that can occur, right? You can have a myocardial infarction where you actually have a weakened muscle that holds the rope of the valve. That's the mitral valve. But normally what we're looking at is patients who have disease states that actually are progressive that can cause this kind of dysfunction. So rheumatic heart disease, uncontrolled hypertension, connective tissue disorders, things like lupus, trauma, congenital malformations, and a big one, even though I'm not sure that everybody sees that, is endocarditis. From the AACN's point of view, they like to ask a lot of questions about endocarditis. Now, we see a lot of IV drug abuse, so we probably see our fair share of endocarditis. In general, in the population of the world, not quite as much IVDA. It's more related to snort and sniff. So you only can really get bacterial endocarditis from IV drug abuse. Okay, so that's a really important one. And that's what stimulates oftentimes endocarditis. All right, so let's just take a quick look at aortic regurgitation. So what you're seeing here is normally your LV ejects into the aorta, the valve closes. Remember that the little bowls on the side of the valve, those are called the cusps. Those fill with blood, and that's what actually translates into coronary artery perfusion. So I want to make sure you appreciate that when your valve is regurgitating, you will always have reduced coronary artery perfusion, because if the valve doesn't close, the bowls don't fill completely. So that reduces blood flow to the coronary arteries. Okay. But the regurgitation itself, so instead of blood going forward, it's coming backwards. Instead of going forward, it's coming backwards. It's going to cause LV volume overload. And typically, what you're going to see is first LV dilation and ultimately LV hypertrophy. So first systolic dysfunction and then diastolic dysfunction. You're going to have a systolic murmur that typically is going to occur because it's really, really, really difficult to maintain mitral valve regularity. So you're going to have a systolic murmur. And then you also have a diastolic murmur. That diastolic murmur is coming from the aortic regurg. The systolic murmur is actually typically seen because you have mitral regurgitation as well. So remember, uncontrolled aortic regurgitation will eventually promote mitral regurgitation. Good. Same thing with aortic stenosis. Eventually we'll have mitral regurgitation. Okay. So lots of times what you're going to see is that as your LV starts to dilate, it's not really dilated here, it kind of is normal, but your LV will start to dilate. The septal wall will shift over to the right ventricle because it's got to make room for all that volume. So basically it's cardiac herniation, right? Your septal wall has shifted. Just like when we look at a head CT, we're looking at the dural folds that separate the right and left cerebral hemispheres from the cerebellum, right? Your septum has moved over to the right heart, making the right heart chamber smaller. So eventually, right? Eventually with aortic regurg, so let's just say you got aortic regurg because you had uncontrolled hypertension. The most common abnormality we see with uncontrolled hypertension is aortic regurgitation. Ultimately, you dilate the LV and you hypertrophy the LV. You now have mitral regurg and you have septal wall displacement over to the right heart. So now I have biventricular dysfunction. And that occurs primarily because of that dilation of the ventricle. Remember, I'm feeding my ventricle from two directions, through the mitral valve and from the aortic valve, and I shouldn't be doing that, right? That's the problem with aortic regurgitation. So really, really important for us to remember that. Now, what this actually tells you, this widened pulse pressure, is that typically you have vasoconstriction of the artery, but you have as a compensatory response, and you still may at some point have preserved ejection fraction. That's going to be kind of in those earlier stages. So very, very important, or I'm sorry, in the later stages, you're going to have ejection fraction because you've got a hypertrophied heart. So what we often will see with these patients is a wide pulse pressure. Okay, now aortic stenosis. So that valve now is stenosed. It doesn't open, right? So the LV is trying to eject against a relatively closed valve. So what's going to happen is that you're actually going to develop more and more and more muscle. That's the hypertrophied left ventricle, trying to eject that blood flow through that stenotic valve. Now that blood flow forward is obstructed. So the truth of the matter is you got to have a valve replacement. That's really the only thing that we're going to be able to do that's actually going to help you is a valve replacement. But what's going to happen as you hypertrophy your left ventricle is that the left atria is going to dilate. It doesn't really have potential to have quite a bit of hypertrophy, although it'll have some. But you are going to dilate that left atria because you can't get volume into the ventricle. So volume stays in the atria and eventually it stays in the veins, which means your venous pressures. So that would be your PAD and wedge pressure, your pulmonary chest x-ray, the fluid in your lung is going to go up because volume doesn't go into the LA, into the LV and out. It can't get into the LV, so it stays in the LA and increases venous distension. Okay, everybody good? And that's a really important concept. It really is meaningful when we're considering what's occurring with our patient. So our LV eventually, over time, is going to hypertrophy. Okay, and this will be a failure to fill, right? So same thing, just remember, you always want to say failure to fill versus failure to eject. Failure to fill versus failure to eject. Okay, doesn't mean that you have a good cardiac output. Doesn't mean that you have a good stroke volume. It just means that your ejection fraction may be relatively normal. Remember what ejection fraction is. You remember from last week? Ejection fraction is well, you have both right and left ventricle. Good, that's perfect. Okay, so ejection fraction says filling and stroke volume. Okay, stroke volume is what your heart ejected out. So it's actually stroke volume divided by filling volume. Okay, and here's the way on the echo that you want to understand that. end diastolic volume minus end systolic volume, EDV, end diastolic volume minus end systolic volume, which is stroke volume, divided by end diastolic volume. And that's what an echocardiogram shows us. That's what we're looking at when we say EF. Okay, so let's just think about this concept, because it's really, the thing is, if you understand concepts, all the rest of it is easy. Is your problem failure to fill or failure to eject? Okay, well, if my end diastolic volume goes down because I can't fill the ventricle, I may have a preserved ejection fraction, but it's a small amount of volume. So I can be ejecting 50% of 100 cc's, which is not the same as 50% of 250 cc's. You understand that? So if your end diastolic volume goes down, your proportional ejection is going to stay relatively constant, but your stroke volume and your cardiac output are poor because you couldn't fill the ventricle. Everybody okay with what I've just said? Because that is really, 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 really important. Again, stroke volume divided by end diastolic volume. Stroke volume is the amount of volume ejected divided by the amount of volume that filled. If you don't fill the heart, your stroke volume is going to go down because you didn't fill the heart, but your end diastolic volume was also low. So when you do that fraction, stroke volume divided by end diastolic volume, the ejection fraction stays the same. Everybody with me? All right, so let me just give you some numbers. Pull your phone out. I'm not going to test you. You guys at home, just, it's really important to put this into numbers, okay? So stroke volume, 100. End diastolic volume, 300. So 100 divided by 300. Should be, did you do that on your calculator or in your mind? 0.33. So now we multiply that times 100 because 0.33 is not in percent. That's a 33% ejection fraction. Your stroke volume looked okay, but you had a high filling volume. So actually this would be systolic dysfunction. On the other hand, stroke volume is 40, filling volume is 75. So 40 divided by 75, pardon me, 53. So you have a preserved ejection, you have a preserved ejection, but you had failure to fill. Everybody see the difference there? And that's really, really important. So when we're looking at aortic stenosis, again, remember, we're going to make some assumptions. We've listened to your heart. We've heard a heart murmur. It's a humming murmur during systole, which means it's occurring generally going to be at the aortic valve, right? It occurred during systole. I have poor blood flow forward. I also, again, can have a reduction in coronary arterial flow, so I can have some chest pain. My heart is working really, really hard. The myocardium is consuming a lot of oxygen, trying to eject blood across that stenotic valve. That can be really concerning and worrisome. So again, these kinds of patients will present with indications of failure to have an appropriate cardiac output or stroke volume. They have syncope, fatigue, they can have palpitations, but also the murmur is going to actually radiate up into the neck. So you can actually hear the murmur in the neck as well. It radiates up to the neck. So lots of times when we talk about aortic stenosis, remember, it'll be described as a humming murmur during systole, radiating to the neck, presenting with signs and symptoms of heart failure. But the difference is you've isolated that systolic murmur and it's radiated up into the neck. Cardiac output is down, CVP, wedge pressure up, and we hear the presence of a systolic murmur. Mitral regurgitation. So mitral regurgitation is rapidly going to decompensate with the filling of volume in the pulmonary veins, okay? Patient is going to present with very similar symptoms. They're heart failure types of symptoms, right? Because instead of the major blood going forward, it's going backward. So again, we're going to hear a murmur, right? That murmur is going to be blowing or whooshing, because that's a murmur of regurgitation. On an exam, that's how it's going to appear for you, right? It's very difficult to differentiate these murmurs by auscultation. But on an exam, it would say your patient has a blowing, whooshing, systolic murmur, or a whooshing murmur, or a blowing murmur, systolic murmur, and their pulse ox is 88%, and on chest x-ray, there is profound interstitial edema. Your patient has poor forward flow, their cardiac output has dropped, their stroke volume has dropped. And the problem is with mitral regurg, what you're actually doing is placing a burden into the pulmonary veins. When you place a burden into the pulmonary veins, you're going to now have pulmonary hypertension. When you have pulmonary hypertension, that's going to ultimately affect your right ventricle. So when we're evaluating this patient, they look oftentimes like they have right ventricular failure, but they have wet lungs. Wet lungs are going to be a sign that something's wrong in the left heart. Systemic edema alone is a sign there's something wrong with the right heart. Pulmonary edema reflects something wrong with the left heart. So that just helps you to appreciate if you've got both pulmonary edema and systemic edema, you have biventricular dysfunction. Does that make sense? Excellent. Okay, I hope online also makes sense. Okay, so with mitral regurgitation, lots of times what you're going to see when you look at a patient who has mitral regurg, because they've distended their atria, that actually will stimulate a couple of things. When you distend the atria, that's actually going to stimulate abnormal focuses throughout the atria to fire, because we have an alteration in the oxygen demand and the oxygen delivery. And frequently what you will see is atrial fibrillation. Whenever you see a patient with new onset atrial fibrillation or atrial fibrillation out of control, you always first and foremost look at the left atria and the right atria in terms of dilation. In terms of dilation. Now that's going to occur for many reasons, that dilation. But on EKG, you're not diagnosing dilation of the left atria or the right atria by your EKG. You're just looking for the presence of atrial abnormality that is secondary to the dilation of the atria. Cool? Okay. Now, most of your blood is in your atria because you keep regurgitating backwards. So your forward flow, your forward flow stroke volume has gone down. Okay. And you have volume in the ventricle because you're getting a lot of volume into the ventricle. So your end diastolic volume is up and your systolic or your stroke volume is down. Okay, now this is going to be a form of systolic failure, but it's a form of systolic failure because you're regurgitating back into the left atria. Okay, so remember, we're going to primarily look at the presence of volume in your veins here. So CVP will be up, wedge pressure, PA, diastolic pressure will be up, and it looks just like heart failure. But here's the thing, with severe mitral regurg, you typically will have a loud holosystolic murmur. Now I'm going to say something here that's not on the slide because I think it's really, really important. Patients who have had posterior or anterior myocardial infarction can rupture the muscle, that's called the papillary muscle, that holds the cord, that holds the valve, the mitral valve. That cord is called the chordae tendineae. It's embedded into the papillary muscle. The anterior papillary muscle is fed by the LAD. The posterior papillary muscle in most cases is fed by the RCA. So remember, if you have an anterior MI, you're going to be concerned about loss of anterior papillary muscle. If you have a posterior MI or an infraposterior MI, you're going to be worried about the loss of the posterior papillary muscle. If that muscle infarcts, the cord is going to rip out. The cord now has ripped out, and my patient has acute, life-threatening mitral regurgitation, because it's not just valvular incompetence, it's a leaflet that is completely flapping in the breeze. That's acute mitral regurgitation. That acute mitral regurgitation is not a process that occurs over time. It happened because of their MI. Okay, so that's a ruptured papillary muscle. The chordae tendoni, which holds that valve closed against extraordinary pressure, has now come out of the papillary muscle because the papillary muscle is infarcted, and that valve leaflet is flopping in the breeze. That patient is going to acutely and profoundly decompensate. Well, what does that tell you? They're going to have a loud holosystolic murmur, and actually, you won't be able to hear S1 or S2. All you're going to hear is shh, 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 shh. You're not going to hear S1 or S2. You're just going to hear a loud holosystolic murmur. So when you see that word, loud holosystolic murmur, and that word in a description on your exam is going to be talking about, number one, acute mitral regurg, or number two, something that you can see when you have an LAD infarct, and that is a ventricular septal defect. Big hole in the septum, valve that's no longer tethered. It's going to give you on your exam with an acute decompensation. So your patient came to the hospital, he has an anterior stem, he went to the cath lab, he's infarcted his whole anterior wall. 4 hours after admission to CVICU, your patient acutely decompensates. Blood pressure's down, venous pressure's up, pulse ox is down. You put your stethoscope on the chest, unrealistic because we never are able to hear this because it's too noisy and most of us don't have great stethoscopes. He's got a loud holosystolic murmur. What do you suspect? And they'll either ask you VSD or acute papillary muscle rupture. Okay. Used to be much more complicated. They would throw in their SVO2, but they're not going to do that now because most people don't use PA catheters. So it's not going to be as complicated. You're either going to have the answer acute mitral regurg or VSD, but just in case, because it comes out of a big barrage of questions. With the VSD, your SVO2 is up. With mitral regurg, your SVO2 is down. Okay, why is that? Because if I make a hole in the wall from the left to the right ventricle, oxygenated blood gets pushed through that hole in the septal wall, and that oxygenated blood now gets re-ejected or recirculated up into the pulmonary bed. So with VSD, everything looks exactly the same. Partial anterior MI, severe significant posterior MI. But now with the VSD, SVO2 goes up. With acute mitral regurgitation, SVO2 goes down. SVO2 goes up with VSD because I'm mixing oxygenated blood with the right ventricular deoxygenated blood and injecting that up into the pulmonary artery. With acute mitral regurg, I just have a poor cardiac output, so that's why, okay? In the last 3 times that I've taken the exam, there was no question about SVO2. But just in case, I just want you to know what that difference is. Okay, mitral stenosis, humming murmur on diastole. The valve between the left atrium and the left ventricle is stenosed, it's very narrow. And again, you're going to have blood back up into the lungs. You're going to have pulmonary hypertension. You're going to have pulmonary edema. You're going to have secondary right heart failure. You're short of breath. You're very tired. Okay, all pretty normal. And it sounds just like mitral regurg. The difference, my friends, on your exam is going to be the murmur. Mitral regurg, systolic murmur, blowing. Mitral stenosis, diastolic murmur, humming. All right. So that's your mitral stenosis. Same thing. Treat your patient just like they have heart failure. The only indicator that you are going to have is the heart sound. And that will be described to you. Okay. Now, where do you want blood to go? Through the path of least resistance, right? And the only way to fix this is what? The only way to fix mitral stenosis is what? Replace that valve. Okay, so we do have some medical management. We're going to reduce your fluid. We're going to restrict your activity. We're going to give you heart failure management, right? You're going to have some diuretics, you probably have some ACE inhibitor, but what you're going to need ultimately is a valve replacement. Now, you can have minor mitral stenosis and live very well with that. But if it's major stenosis and your forward flow is significantly limited from left atria to left ventricle, you're going to have a valve replacement. Okay, so surgical management, lots of different things that we can do. A lot of different things. Don't worry about this. No one's going to ask you what kind of valve repair your patient's going to have, right? But you just want to know. Valvuloplasty is a repair of the valve. Commissurotomy means that we're separating the valve leaflets and the stenotic valve, and then we look at valve replacement. And there's multiple ways to do valve replacement. And post-op care is going to be just like any post-op care for open heart surgery.
Yeah, I'm over here fucking sleeping in the fucking car.
Okay. Excellent. All right. So let's think about one of the other causes for valvular dysfunction. That's inflammatory disease, endocarditis, and that just comes from infection of microorganisms. This does tend to be something that AACN likes to ask you about, infective endocarditis, right? So it's microorganisms that are circulating in the bloodstream and get deposited onto the endocardial surfaces and the valve leaflets. So endocardium is inside, that inside muscle, and particularly at the valve leaflets. And so that will actually damage your valve because of the bacterial growth. So again, it's an inflammatory disease, very often from infectious organisms. We did see some evolution of endocarditis with COVID-19 with that viral component. Those were microorganisms, they were viral, not bacterial. So most commonly it's from bacteria. And that bacteria deposit on the valve leaflet causes basic vegetation. So when we're actually evaluating the patient, we can see vegetation formed on the valve, and it makes the valve look like a piece of cauliflower. Valves are typically nice and smooth. So on echocardiogram, you'll see a cauliflower-like appearance. And those valves now are damaged and dysfunctional. They also have the weight of the bacterial growth on them. This is all quite important in terms of how it makes that valve dysfunctional. This is life-threatening. Endocarditis is life-threatening. Now, first and foremost, of course, we're going to do antibiotics that are programmed and specific for the bacterial growth. But frequently, these patients are going to need emergent valvular surgery. So we've got to get antibiotics on board first, and then they're going to go to have valvular replacement. The problem with endocarditis is once that bacteria has been deposited, it can become malignant in its reproduction. And that malignancy can destroy the cords. So once the cords are destroyed, the valve is totally floppy and you're not going to have any management of forward flow. Patient could have sudden cardiac death. Okay, so attacking the cords, also attacking the papillary muscle, which tends to have a kind of an abundant oxygen delivery and is very attractive to the bacteria. Okay, and also attack of the conduction system. So those are things that we can see with infectious process and endocarditis. Most common is strep, which is pretty unfortunate, but we can see all other types of bacteria, but we can also see fungi. And it's very important to remember that endocarditis most frequently affects the mitral valve. Just because it gets deposited in the first valve after it's left the right heart, gets deposited in that first valve. So that's why the mitral valve is more frequently affected. If you have a larger growth of bacteria, then there can be transmission through the LV up into the aortic valve. But you have to be actually carrying that bacteria forward for that bacterial, and it's really bacterial endotoxin. It's not the actual direct bacteria, it's the endotoxin from the bacteria. And that deposition also depends on the content of endotoxins in your blood and how that deposits on a valve. Okay. All right. So almost never occurs in people who have normal hearts. Very common to see with IV drug abuse. And the second most common issue is going to be patients that have had a history of rheumatic fever. So those are the two things that usually the AACN will ask you about. If you've had endocarditis before, it's likely you will have it again. That's really, really important. And any kind of valvular abnormality puts your valve at risk for deposit of endotoxin. So if you have a prosthetic valve, if you have congenital heart disease, you have congenital valve defects, those can actually.
So I think you lost this.
Okay, my friends online, just remember that you need to mute yourself if you're on Zoom. I would so appreciate it. Thank you very much. You don't automatically get muted. Thank you so much, my friends. All right. So presenting symptoms. So lots of things that sound like heart failure, but the murmur is new. And the patient typically is going to complain of fever, chills, night sweats. They may have some weight loss. Okay, usually with heart failure, you have weight gain. Here, they may have weight loss. So a lot of things that sound like heart failure and the description of heart failure, but the identifier for infective endocarditis for you will be the presence of similarity to infection, to having a bacterial infection, fever, sweats, chills, cough, and of course, a positive blood culture. Okay, so really important. Again, trying to differentiate all this from heart failure requires a lot of energy and effort, but descriptions of patients will be presented to you and you're going to anticipate. That's what this is about. Can you anticipate what's going to happen next? Not that you have to be an extraordinary diagnostician, but can you anticipate what's going to happen next? Okay, so antifungal, antibiotics after we've identified the organism. If you need oxygen, typically you don't. And if you're presenting with signs and symptoms of heart failure, we're going to treat the heart failure, just like we do normally for diastolic dysfunction and or systolic dysfunction. So really important. And of course, ultimately, you may require valve replacement. All right, done with all that. Going to now talk about the progression. Cardiomyopathy, valvular dysfunction, heart failure, and acute myocardial infarction. Everything we've talked about, how that progresses into cardiogenic shock. Okay, so cardiogenic shock, I think we talked about this last week, but you know what? I can't remember from week to week because I'm doing so many other things. Do you recall that we talked about cardiogenic shock last week? I'm not sure. Pardon me? Okay, good. Excellent. Then we're going to talk about it now. Yay. Okay, so progression of myocardial infarction, progression of severe acute valvular disturbance, progression of heart failure, progression of cardiomyopathy is to cardiogenic shock. Cardiogenic shock is actually evaluated as a systolic blood pressure less than 90 for at least 30 minutes. This is the ACC definition. And is secondary to myocardial dysfunction. So again, cardiomyopathy, heart failure, acute myocardial infarction, okay? So systolic blood pressure is down, cardiac index is down. Remember, normal cardiac index by AACN standards is 2.5 to 4. So cardiac index is less than 2.2, and you have a high presence of volume in the veins. So your wedge pressure is greater than 18. Your CVP typically is greater than 12. CVP should always be lower than wedge because CVP is about filling the right heart. And the right heart is a thin wall with a big diameter, and the left heart is a thicker wall with a smaller diameter. So wedge pressure up, lungs are wet, cardiac index less than 2.2, systolic pressure less than 90, and you suspect myocardial dysfunction. Now, other signs of tissue hypoperfusion. So one you really are going to need to know, we'll talk about it more when we talk about the kidney, is the weight-based measurement of urine output over time. Ooh, that was a big mouthful. Weight-based measurement of urine output over time. So with a collection of urine over 6 hours, 8 hours, or 12 hours, 6, 8, or 12, averaging that urine output per hour. Okay, so I'm just got to make it easy for myself. For 6 hours, you have 600 mLs of urine output. That means 100 mLs per hour. And then that gets divided by your body weight. So average over a period of time divided by your body weight. And what is considered normal urine output, and you will have to know this because this is the standard, even though we may not participate in that standard because we might not even be measuring your output. The standard is for an adult that has appropriate renal flow. And that requires a functional heart to have good blood flow to the kidney. The normal urine output is 0.5 mLs per kilogram per hour, 0.5 to 1.5. Anything lower indicates poor renal blood volume and pressure. Anything higher indicates failure of the kidney to regulate you. So it's going to be very important for us to appreciate the standard urine output for adults greater than 0.5 mLs per kg per hour looked at over an average period of time, 6, 8, or 12 hours, and less than 1.5 mLs per kilogram per hour. So that's the range. Now I've got cardiogenic shock. So that word tells you this is heart failure. I have no, I have very poor forward flow. I don't have enough volume or pressure driving flow through my kidney. So my urine output's gone down. Okay, now remember the question you always ask. Do you have volume? Yes or no? And if the answer is yes, where is it? If it's in the arteries, you can maintain your systolic pressure. If it's in the arteries, your cardiac index is up. If it's in your arteries, you have good renal function. If you have volume, yes, but it's not in the right space, you find the presence of volume in the veins and in the interstitium. Remember, we talked about that question before. Do you have volume, yes or no? That's the question. So when you're looking at an exam, you're looking for presence of volume in the artery by systolic blood pressure, by cardiac index, by urine output, by capillary refill, by temperature and pulses. And if you don't have volume in the artery, your next question is, do you have it in your vein? Your lungs are wet. Your system is wet. You've gained weight. Do you have volume? Yes. Is it in the right place? No. So when you're looking at somebody with hypovolemic shock, they don't have volume in the artery and they don't have volume in the vein. They don't have volume. With cardiogenic shock, you don't have volume in the artery, but you got volume in the vein. Does that make sense? It's a really simplified way to look at this, to actually be sure. So remember, you're going to have prolonged capillary refill time. You're peripherally vasoconstricted. So typically your extremities with cardiogenic shock, typically your extremities are cold because you're vasoconstricting and shifting blood flow to the two primary oxygen requiring organs. Those are called essential. Essential organs means that they are essentially dependent on oxygen, the heart and the brain. Once you start to see a significant alteration in mental status, that means you don't even have enough blood flow to maintain cerebral oxygenation. That's really worrisome because that means you're having a failure of your compensation. Okay. So really quite important in relationship to that. Okay. So cardiogenic shock, signs of systemic hypoperfusion, and that's an LV dysfunction. I have poor forward flow. I've got volume. Yes, it's in the veins. And it's primarily in the pulmonary veins. And we know that. You don't have to have a PA catheter. You know that because you looked at a chest x-ray. And you may get a chest x-ray to look at. By the way, no one wants you to be a radiologist. If you have a chest x-ray, it's either going to be clearly all black, or it's going to have all sorts of white. And when it's got all sorts of white, that's telling you that that is infiltration. The black tells you it's air. Air doesn't absorb the X-ray, so the X-ray passes through the lung. But when it's all white, that's fluid. Fluid is absorbing the X-ray, basically, and that's why you see all that white. So, poor cardiac index, high pulmonary venous pressures, and lung infiltration. That's LV failure. RV failure, have a low cardiac output, but your CVP is what's elevated, and you have systemic infiltration. That's pure RV failure. Now, most of the time, you have biventricular failure. So you got wet lungs, wet system, poor flow. So we'll remember when we looked at heart failure last week, we talked about warm and wet, warm and cold. Warm and wet, warm and dry, cold and wet, cold and dry. And the worst is cold for peripheral flow and wet, presence of volume in the veins. Cold and wet, class 4 heart failure, cardiogenic shock. Cold and wet, class 4 heart failure, cardiogenic shock. Okay? Pretty straightforward. Now, this is just showing you basic what we call encephalization. That shows that upper lobe vascular redistribution. So what you're actually seeing is the vessels here are engorged. Again, no one's going to ask you to actually diagnose that. There may be a reference to this term, curly B. Curly B are these, basically are these horizontal lines that actually appear near the end angles or the costophrenic angles of the chest X-ray. So you see the difference between here's your normal and see all that engorgement. That's just pulmonary vascular engorgement. I now am actually able to see the pulmonary vessels, mostly in the dependent surface of the lung. And that is known. Curly is, I always thought curly means is in curls. No, curly is the name of the physician who identified it. So curly B lines actually are highly indicative of profound pulmonary congestion. So no one's going to ask you about all this other information. They're just going to say, do you have curly B lines on a chest X-ray? So they might say you have infiltration with curly B lines. They might not say that, but you just want to know it. Okay. Now this brings us to the common denominator of all kinds of shock, all kinds of shock. All shock is defined not by hypotension. It's defined by the evaluation of inadequate perfusion. So inadequate perfusion is identified to you by the fact on your exam, you will have lactic acidosis and metabolic acidosis. So lactic acid is up. When lactic acid is up, and that's a cause, your metabolic acid, which you never measure, which is hydrogen, your hydrogen ion is up. So your lactic acid is up, your hydrogen ion is up. Hydrogen binds to bicarb or circulating buffers. So the way you identify metabolic acidosis in the presence of shock, lactic acid is up, base and bicarb are down. Lactic acid up, base and bicarb down. Now remember, they don't want to confuse you. But here at Grady, we're always trying to confuse you because on your chemistry, it's not called bicarb, it's called serum CO2. So when serum CO2 is down, you have to assume metabolic acid is up. Serum CO2 on the chemistry. On your blood gas here at Grady, you get a base deficit. Most hospitals give a bicarb and a base deficit. It doesn't matter. Base down, bicarb down, metabolic acid, which is hydrogen, is up. And then you look at lactic acid is up. Lactic acid, base, lactic acid up, base and bicarb down. This is basically measuring a shift to failure of glucose utilization. That's a metabolic disturbance, that's the lactic acid, and a failure of the oxygen transport and conversion of lactate to its end product, pyruvate. Nobody cares. I don't even know why I said it. Sorry, don't write it down, don't worry about it. Lactic acid is up, base and bicarb down. Okay. Now, as we first see our patients who have lactic acidosis and metabolic acidosis in the face of cardiogenic shock, This is an emergency. Immediately, we have to try to restore blood flow. So just remember, restoration of blood flow does not necessarily mean restoration of blood pressure. Okay. So in addition to thinking about trying to get patients' blood pressure up using vasopressors like norepinephrine, epinephrine, neosynephrine, or whatever you're using, you also need to remember that you need to assure forward flow. Okay, now you've got cardiogenic shock. So assuring forward flow is typically not to give the patient volume, but to give the patient what? Inotrope, right? Not volume, inotrope. And when you have a patient with cardiogenic shock and you're chasing that blood pressure and you're titrating up on norepi and epi, you may actually be further exacerbating the heart failure. So it's really important in cardiogenic shock to recognize that you want to improve forward flow, that by necessity, you want to get that mean pressure up, but you've got to remind yourself that the excessive use of vasopressors in this patient population can be very dramatically making that patient worse. Okay, good. All right. So now let's just take a look at this case. 62-year-old male brought to the ED with sudden onset chest pain, excessive sweating, nausea, and dyspnea. Okay, today is Wednesday. On Monday evening, I got called by a CVICU nurse who was in the ED with her husband, who had severe sudden onset chest pain, unresolvable, excessive sweating, nausea, and dyspnea. He was so diaphoretic and cold. She called me and she said, "Can you come down here? Would you just come down and take a look at his EKG?" Not because she didn't trust anybody, but I think there was a little delay in the physician looking at the EKG. I'm not sure why. I came down, I looked at the EKG with Jacob, and Jacob said, "Look, he's infarcting his whole heart." No, that typically isn't what happens. For this patient, the patient who presented, he's a 40-year-old male in the ED with sudden onset chest pain, excessive sweating, nausea, and dyspnea. EKG was really important. EKG is going to give us a differential. Are you having a STEMI or is it something else? Okay, for him, it was something else, thank goodness. Okay, so patient comes to ECC, you don't know anything about them. That's the hardest thing about being in the ECC. You don't know anything. By the time the patient gets to the unit, the ECC's already diagnosed them. It's much easier to care for patients in the ICU because we already have an idea what's wrong, but the ED is who's figuring that out. Okay, so he's really agitated on presentation. His heart rate is 135, tachycardia. His blood pressure is 80/60, hypotension. Tachycardia, hypotension, and he has the actual evaluation that he has poor oxygenation. His SATs on room air is 62%, doesn't have any history, and he has tachypnea. Tachycardia, tachypnea, low SAT, you're in shock. Okay, cold, clammy skin, cyanosed extremities, gallop rhythm, meaning S1, S2, and 2 diastolic sounds, S3 and 4, early filling, late filling, and lungs are wet on chest evaluation. And here's this patient's EKG. Okay. Okay, so does everybody agree you've got acute ST segment elevation? Okay, you might have looked at that and said, this is VTAC. Oh no, it's not VTAC, it's ST segment elevation across the whole anterior wall. So anterior septum, V1 and 2, pure anterior, V3 and 4, lateral, V5 and 6, and also 1 and L. But you actually have reciprocal changes, and that's what really helps us differentiate this. So you have ST depression in 2, 3, and AVF with ST elevation in the pure anterior with septal and lateral extension. He's having a pure, full-blown anterior MI. Typically, you would see this with a left main occlusion. Okay, on the patient I was talking about, he had ST segment elevation peppered throughout, no reciprocals, but he also had something called a coving of his PR interval, which you can't see here. You wouldn't be able to see it here, but he had a coving of his PR interval, which almost always is pericarditis, and that's what he had, pericarditis. Okay, now we take a look at the chest X-ray. Everybody see how you've got all this infiltrate here? You have engorgement of the cephalization of your vasculature. You also have curly B lines. You have a big old heart, right? Your patient's in shock. He's in cardiogenic shock. So remember, when you're evaluating your patients, you got to do a differential diagnosis. And when you're evaluating, you're looking at those signs of heart failure, you need to consider, is there a possibility of a pericardial effusion? And could it be acute, like a cardiac tamponade? Because that's a pericardial effusion that occurs acutely because the accumulation of blood happens rapidly. Got to look at dysrhythmia. Got to consider, does the patient have an MI? Now, we already know that about our patient because we looked at his EKG. He's having an acute anterior MI with lateral and septal extension, and he has inferior reciprocals. What's the first thing you want to do for that patient? Get thee to a cath lab. Time to an open artery. Go now and go fast, right? Don't pause to give Plavix and heparin and other things. Don't pause to get familial information. As soon as we can get that patient on the cath lab table, the better, right? Okay, good, excellent. So I just want to remind you about your cardiac cycle. So actually, I'm so sorry, this should have been blue and it's kind of mustardy yellow, but wedge pressure measures oxygenated blood. Left ventricle delivers oxygenated blood through its work into the mean artery, and that sustains your mean arterial pressure and your systolic pressure. The system maintains this pressure by vasoconstriction or relaxation, that's SVR. The system maintains that pressure in order to also ultimately fill the right ventricle. We look at right ventricular filling pressure as CVP. We look at left ventricular pressure as wedge pressure or PA diastolic. And we look at the presence of fluid in the lung and presence of fluid in the system, okay? RV failure, CVP will be high. We have systemic edema, but the lungs are dry. LV failure, the lungs will be wet. Wedge pressure, PAD will go up. LV failure, filling pressure to the left heart goes up. RV failure, filling pressure to the RV goes up. And when you have biventricular failure, everything goes up. All filling pressures go up, both. You'll have wet lungs, wet system, high wedge, high CVP. Okay? So this is just kind of I felt like it was a nice visual. You can see it's from an English publication, British Journal of Critical Care, just that you've got a family in LV, you get pulmonary edema, that fluid in the interstitium compresses the alveoli. So now my lung is non-compliant. I'm going to have to, as I observe my patient, I see the presence of tachypnea, and they're not really moving a lot of volume. So they're going to start using accessory and abdominal muscles because they're have to generate more negative pressure to try to get gas into the lung. Okay, that increasing negative pressure is going to change the preload volume because that's going to suck volume back into the right heart, which then is going to increase RV work, which then is ultimately going to cause LV dysfunction. So this is a chain of events that's really important for us to think of and to understand, but also the complexity of which will not be asked about on your exam. So I just want to remind you, when we're thinking of shock, and shock is really at the very end, we'll talk a lot about shock and SVO2 at the very, very end, just reminding ourselves that there are three components of arterial blood volume: the amount of volume you have, the integrity of your vessels, both your arteries and veins, and the integrity of your heart. Okay, failure of your heart is going to lead to shock. Failure of your vessel tone is going to lead to shock. Failure of your volume is going to lead to shock. And most of the time, you see more than one component presenting in failure. So again, you always want to remember that when we look at shock, we first start with cardiac output. Normal cardiac output by ACN's standards is 4 to 8 liters a minute. Cardiac index is cardiac output adjusted for body surface area by ACN. That's 2.5 to 4 liters per minute, meter to a meter square. Okay, cardiac index, and that's the better measure. Okay. Underneath that is stroke volume and heart rate. What you need to focus on your exam and in your clinical practice is stroke volume. You're always trying to improve stroke volume. And when you see patients with persistent tachycardia, that is a compensatory mechanism for low stroke volume. So now the question is, do you have volume, yes or no? And where is it? Because if you've got volume and it's in the veins, but your stroke volume is poor and you are suffering, you're in acidosis, you've got renal dysfunction, you need an inotrope. You've got cardiogenic shock. If you don't have volume in the arteries and you don't have volume in the veins, you need volume. When the problem is loss of vascular tone, I'm going to try to restore that with vasopressors. And then I'm also going to assure you got volume and that you've got inotrope. You might need both. Does that make sense? So that's how you define shock. That's how you define what the shock is. Okay, SVR, systemic vascular resistance. Again, no one's going to ask you to calculate it by AACN standard. It's going to be roughly, normal SVR is 800 to 1200 dynes per second per centimeter to the fifth power. Okay, you don't have to worry about any of that, 800 to 1200. Low SVR occurs when you have a high cardiac output and when you have decreased vascular tone. High cardiac output with decreased vascular tone. Low SVR, less than 800. High SVR occurs when you have reduced cardiac output and higher vascular tone. That's all. Okay, so no one's going to ask you to calculate it. We talked about it before. We talked about it, I think, the first week we were together. We talked about vascular resistance, SVR, MAP minus CVP divided by cardiac output times a dynes converter, which is 80. No one's going to ask you. It's just foolish to ask people formulas today. Formulas are available on the internet. We can look them up. We don't need to memorize them. But MAP, beginning of the circuit, CVP, end of the circuit, MAP minus CVP, divided by your blood flow, which is your cardiac output. MAP minus CVP divided by cardiac output. And then you convert that into dynes, and that's 80. Normal SVR, 800 to 1200. Normal PVR, which is a reflection of right ventricular afterload, normal PVR less than 250. Left heart works hard, right heart hardly works. SVR to the left heart, 800 to 1200. That's a lot of resistance that the LV has to eject against. RV hardly works because it doesn't have to eject blood against a high resistance surface normally. Okay. And then just reminding ourselves, we're going to evaluate tissue perfusion by base deficit. Here at Grady, we use base deficit, but also bicarb. When base goes into deficit, bicarb is also going down. Base deficit, decreased bicarb, metabolic acidosis. And then we look at SVO2 and SCVO2. We're going to talk more about that. But SVO2 and SCVO2 are a measure of the reserved oxygen that remains in the venous circulation after blood has passed through all your capillary beds. So when I have inadequate delivery of oxygen, my SVO2 will be low, because my tissues are going to be using more of the oxygen reserve because it didn't get enough delivery. Now, I think we talked about the components of oxygen delivery, but just in case we didn't, number one and most important is the cardiac output. So if I don't have volume, I don't have inotrope, I'm already at severe risk. Number one compensatory mechanism for oxygen delivery is cardiac output. Your patient will increase his heart rate in order to compensate that. Your goal is to treat the stroke volume so the heart rate can come down. Okay. Second is oxygen carrying capacity. That's the hemoglobin. So cardiac output, number one, hemoglobin, number two, and number three is the amount of oxygen your hemoglobin is carrying. And that would be your SaO2. Cardiac output, hemoglobin, SaO2. So if my SaO2 is 65%, like that patient, 62%, my SaO2 was 62%, you better darn be able to make that up with a good cardiac output. Okay, but you've got an MI, so you can't make a good cardiac output. So what do you have? Sustained profound tachycardia, and you have metabolic acidosis. We know that because you're breathing fast. You're blowing off acid to compensate. Everybody get that whole picture? It's a really important picture for us to appreciate and understand. Okay, so always really important for us to remember that patients can have urgent disorders that quickly become emergent. So acute coronary syndrome, hypertensive emergency, okay? So very, very, very important. Hypertensive emergency, that blood pressure is so high that you now, your vasotone is so significant that you now have mitral regurg and pulmonary edema because of your hypertension. You have aortic regurg, mitral regurg, pulmonary edema. So you got to get that vascular tone under control. You're going to drop it about 25% in the first 2 to 3 hours, and then going to be a little cautious after that. So first with vasodilation and then loop diuretics. Okay. Dysrhythmias that interrupt your ability to manifest forward flow. So Brady dysrhythmias, VTAC, VFib, other kinds of dysrhythmias that interrupt forward flow. You got to control that. Acute mechanical causes. Okay, so after acute coronary syndrome, you've had an acute MI. Big problem is you can open up a wall in your ventricle. That's the VSD. This happens with acute anterior and anteroseptal MI. You can rupture your papillary muscle, flapping your mitral valve. That is acute mitral regurgitation. You also, depending on that surface, and it's typically with an anterior MI, if you have infarcted full wall on your anterior left ventricle, you can rupture the wall, which means that you are now bleeding into your pericardial sac, which means you now have a cardiac tamponade. Okay, so these are emergencies that came from an urgency. Always got to have an echocardiogram. It's always going to help us. And of course, acute pulmonary embolism is a form of obstructive shock, obstructing blood flow from going from the right heart to the left heart. So very important to remember with an acute pulmonary embolism, not a saddle. A saddle is, you're going to die. Yeah. But if you have submassive, not a massive, which is saddle, submassive PE, you're actually going to go to the cath lab. You're going to be diagnosed, and you're diagnosed quickly because your RV is acutely dilated. That's what we look for on echocardiogram, is an acute dilation of the RV with the septal wall moving over to the left heart. We're going to get you to, typically we're going to try to get you to the cath lab, where we're actually going to use a pulmonary artery catheter to deliver thrombolytic agents into the pulmonary vasculature. Okay. And that is really, really important. We might actually be able to remove the clot, actually do a thrombectomy, but very likely what we're going to do is utilize a pulmonary arterial catheter to deliver thrombolysis. So in general, in a hospital that has a cath lab, the only reason we do thrombolysis when we're talking about cardiac, the only reason we do thrombolysis is because we have a cath lab. So typically we don't need to do thrombolysis. It used to be that you would administer streptokinase or one of its children, alteplase or whoever, any of the ACE drugs. You would administer those because you thought patients had acute coronary thrombosis. But we don't do that now. We just get you as quickly as possible. So just remind yourself about that. This is just a lovely kind of cardiogenic shock visual. This visual is from the Cardiogenic Shock Collaborative. It's just a really nice visual that just says, if you've got refractory cardiogenic shock, right? We're going to consider that you might need mechanical circulatory support. So this should be in the handout that I sent to you. It might be too small for you to see really well, but mechanical circulatory support means that the question is, Do I need to do a mechanical support of the LV? Mechanical support of the LV will consider that I'm going to give you a balloon pump, an intra-aortic balloon pump, a left ventricular impeller, a left ventricular assist device. That's an external device that you can go home with. And also I will consider, if you have failed medical therapy, I will consider VA ECMO. VA ECMO means that I am going to bypass both the heart and the lungs. I'm going to oxygenate your blood outside. I'm going to return that blood into the aorta. VA ECMO. So VA ECMO is the only kind of ECMO that you would do for somebody who had refractory cardiogenic shock. So remember, you've done medical therapy, and what the question would be is you've done this, you've done common resuscitation, you've done epi, you've done norepi, you've done dobutamine, you're on vasopressin, you're on milrinone, patient's still failing. Now you're going to move to mechanical circulatory support, and you're going to do it fast. Because the patient's going to die if you don't do it fast. Okay, so really, really important when we're thinking about our patients, that's going to be considerate. Yes, please, whoever is talking, would you please mute your phone, my friends, please? We've got some chats here that are reminding you that you are not muted. All right, I'm going to take a minute. I'm going to say, look at that. We've got a lot of people who are not muted. Okay. So I had to go in there and do it. Okay. I think everybody else is muted. It sounds like all the words are gone. So just remember, when you join Zoom, Zoom doesn't automatically mute you. You have to mute yourself. Okay. So beautiful. And thank you guys. All right. There's a lot of information in this visual. This information would be necessary for you if you were taking the CSC or the CMC, that's cardiac medical certification, cardiac surgical certification. But a lot of this information, like cardiac power, like pulmonary arterial pulsatility index, not going to be on your AACN exam. What I want you to remember is if your patient is refractory to medical management, these are the common medical management tools that cardiology will use. Most of us do not use dopamine anymore. Cardiology might use that. So dopamine, epi, norepi, milrinone, dobutamine, vasopressin, patients still refractory. Now we're going to consider mechanical support. We're going to support the left heart if it's the left heart that's failed. We're going to support the right heart if it's the right heart that failed. And we're going to do biventricular support if both ventricles have failed. So that's really all you need to know, because if your patient has failed medical therapy, the question will not be, would you prefer Impella to ECMO? Or does the balloon pump compare to the Impella? No one's going to ask that. You're going to have one thing that you're going to consider, but just be sure you know that if in that list it says VV ECMO, that's not going to be your answer. Okay, cool. All right, very good. Okay, so thinking about doing open heart surgery, we're going to do open heart surgery for valvular dysfunctions. We're going to do open heart surgery if we have atherosclerotic plaque, but not thrombus, or if we have diverse atherosclerotic plaque that we can't manage in the cath lab, right? In the cath lab, typically you're going to try to do thrombolysis, you're going to do a stent placement, you're going to manage that way. But if you're not able to manage in the cath lab, or the disease is too diffuse, we're going to consider open heart surgery. Open heart surgery in general for valvular replacement, although we can do some transcutaneous valve replacement, that isn't done everywhere, so there won't be questions about that. Everybody, every hospital who manages cardiac patients has the who has a cath lab, let me say it that way. Every hospital that has a cath lab has access to open heart surgery. Okay, so we're going to do open heart surgery. We're going to bypass the heart, and we're bypassing both the heart and the lung. So basically, this is short-term VA ECMO. Cardiopulmonary bypass is VA ECMO. Make sure you appreciate that. Now I'm going to take you on to a bypass because I want to actually offload the heart. I need to stop the heart or slow the heart in order to do surgical repair in and on the heart, right? So that's what's going to happen when you go to the OR. Okay. Now, as soon as that patient, not a question about what kind of cardiopulmonary bypass are you doing, blah, blah, blah. Question is, what's going to happen when the patient comes to you post open heart surgery? Okay. So the biggest issue is this: bleeding. 100 cc's or greater from your chest tube per hour actually is going to require notification and may require intervention. You're going to notify the physician. The physician is going to determine the intervention. You have to be aware that this is concerning. Okay. Those patients who come out post-pump, they often have post-pump myocardial ischemia because blood has gone through a filter and that actually has stimulated inflammation. So they have ischemia. They may have dysrhythmias. The most common dysrhythmia will be atrial fibrillation. Unlike cardiac cath, after cardiac cath intervention, the most common dysrhythmia that you're going to see are occasional bursts of ventricular tachycardia. Post cardiac surgery, the most common thing you see is atrial fib, and that's partially because of the volume relation. Now, patients typically who are on pump typically their heart is slowed or stopped and they're hypothermic. So they come out with hypothermia, which causes a very significant vasoconstrictive response. So when they come to us from the OR, they're vasoconstricted and cold, and you're going to apply a vasodilator. And you have to pay a lot of attention because as they start to rewarm, they are going to naturally now vasodilate, and you are now going to add vasoconstrictors. So when they first come out, we vasodilate. We vasodilate, and then an hour to 3 hours, they're going to start to vasoconstrict. Okay. They're going to start, I'm sorry, I'm confusing myself. So sorry. So immediately post heart, because your patient's hypothermic, they will be vasoconstricted. You're going to apply vasodilation. That will help restore their temperature. It helps restore their perfusion. But then they're naturally, as they warm up, they're going to vasodilate. So now you have to add a vasoconstrictor. Now, lots of times we're bypassing that today because we don't see acute hypothermia in cardiac surgery. So that's always really important for us to consider when we're looking at those patients. So hypothermia also promotes consumption. Basically, I'm just going to say consumption or aggregation of platelets and deactivation of platelets. So patients oftentimes post-op are coagulopathic. Okay, so if you're hypothermic, you'll be coagulopathic. And that's always really important to remember. If you're hypothermic, you'll be coagulopathic. You're also coagulopathic because your blood was taken out and run through a machine. So that's another reason that you might be coagulopathic. The single most important concern and what you'd be asked about with post-op cardiac surgery is not all of the vagaries of the cardiac surgical patient except for vasoconstriction, vasodilation. Those are going to be common things that would be asked. Is going to be cardiac tamponade. Okay. Now, what's important to remember about cardiac tamponade is that it's accumulation of fluid in the pericardial space. The difference between pericardial effusion and a cardiac tamponade, slight difference. Pericardial effusion or pericarditis is typically a slower accumulation of lymphatic fluid. Cardiac tamponade is a rapid accumulation of blood. So with a tamponade, you have blood typically, and with pericarditis or a pericardial effusion, you have lymphatic fluid. Pericardial effusion is typically a slower process. Cardiac tamponade is a rapid process. So you're taking care of a post-op heart or a blunt chest injury and trauma, and all of a sudden, cardiac output drops. They have chest tubes. The chest output also tends to drop, the chest tube output. Because if I'm draining the blood, it won't tamponade the heart. We're not draining this blood. It's accumulating in the pericardial sac. So chest tube output goes down. Blood pressure drops. Pulse pressure, the difference between systole and diastole, narrows. Okay. They have an increase in heart rate. And because these are post-op surgical, cardiac surgical patients, typically they will have a PA catheter. That's really the population patients that still get PA catheters. Their wedge pressure and their CVP both elevate, and they elevate equally. Okay. Now remember, the left heart is more muscular, the right heart is less muscular. So normally wedge pressure is higher than CVP. But post-op cardiac patients who have a cardiac tamponade, CVP and wedge pressure go up, and they go up equally. So that's really, really important. They'll have jugular venous distension. Their lungs will be wet. They have severe, if they can tell you, because a lot of times they're intubated, so they can't tell you, but if they can tell you, they have severe shortness of breath. They feel really lightheaded. But the thing the AACN wants you to know is Beck's triad, named for Dr. Beck, hypotension, CVP, JVD, and as the fluid accumulates in the pericardial sac, and it does it rapidly, the heart is farther from the chest wall. As the heart is farther from the chest wall, the heart sounds are muffled. Okay, again, this is for a test, because by the way, you can't hear those heart sounds. You're having an emergency. You're not listening to the heart sounds. What you are going to do, though, is on your A line, because you will have an A line, and on your EKG, you're going to see two really important things: pulsus alternans and electrical alternans. So pulsus alternans called pulsus paradoxus. It's a variable change with inspiration. If you're on a ventilator, inspiratory pressure goes up. If you're not on a ventilator, which you will be, your inspiratory pressure goes down, and you'll have electrical alternates. Now you are obstructing flow into the heart, because as the blood accumulates in the pericardium, you're compressing the heart. That's the tamponade. The heart gets compressed, 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 which means you'll have electrical event, but you will not have pulses. And that's PEA. That's an obstructive shock, because you're obstructing the filling of your ventricle. Okay, this is how pulsus alternans looks. Up, down, 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 up, down. You know where that came from? It doesn't matter. Okay. So just reminding ourselves, this is really about a buildup of fluid rapidly in the pericardial space, compressing the heart. Most common cause is that I've had a free wall rupture after an anterior MI or post-CABG. You can see it with other things, particularly when we're talking about trauma, but really the big ones are MI, CABG, trauma. Okay. Have that again, just because I thought it was so important. Okay, so diagnostically, although you probably wouldn't have much time for this, you would see normal chest X-ray here, and this very wide end. First of all, really almost have a widened mediastinum, and this very large globular shaped heart, and that's from the pericardial fluid. So you can almost see the cardiac shadow, but you have this fluid surrounding that. Okay, again, no one's going to ask you to do that. Okay, so remember, if the patient is awake and alert, it's going to tell you he's really short of breath. You're going to see that because if they're on SIMV, they're going to be breathing above the ventilator. If they're on assist control, they're going to be breathing rapidly. You've set the respiratory rate at 15, but they're breathing 35 times a minute. They're short of breath. They have PEA, so they have electrical activation, but not mechanical response because they didn't fill their ventricle. They have Beck's triad, JVD, hypotension, muffled heart sounds. Always know that when that's mentioned, Beck's triad, or the individual things are mentioned, JVD, hypotension, muffled heart sounds, that means cardiac tamponade. If you could hear it, you would hear a pericardial friction rub. Pulse pressure is narrow, systole and diastole become closer together. They have that pulsus alternans, CVP and wedge equalize, cardiac output SpO2 go down. And when we look at an echocardiogram, the first thing you're going to see is a collapse of your A, because that's the most collapsible chamber. Okay, so pulsus alternans and also electrical alternans. So what you're going to see, you can see it here really well in lead 3 and lead 2. Big, small, big, small, big, small, big, small, big, small, if it was continuing along there. So down here, you've got a rhythm strip. big, small, big, small, big, small, big, small, big, small, electrical alternans and pulsus alternans. So from EKG, from the arterial pulse, from the CVP and the PAD or wedge pressure, and your index of suspicion, your patient's got a cardiac tamponade. Now, sometimes you can see very significant ST segment elevation. And again, this you're going to see with pericarditis as well as cardiac tamponade. You can see that you're going to have ST segment elevation in almost all your leads. This is what, remember I mentioned to you the husband of one of our nurses who came in to the ECC with acute severe chest pain, radiating to the back. So they thought it might be aortic dissection, but his EKG looked like pericarditis. Okay, so if you have time, you're going to get an echo. Normally you don't have much time. Okay, always want to treat the cause, right? Very first thing though is we're going to give you a pericardial window, or we're going to give you a pericardial centesis. So we're going to draw blood out of that pericardial sac. We're ultimately going to actually put a pericardial window in, but we're going to draw blood out of that pericardial sac. May have to do a pericardial window. That'll happen in the OR, but I'm going to draw that blood anywhere you are, in the ED, in ICU, wherever you are. I'm first going to draw that blood out of that pericardium, okay, to relieve the pressure on your ventricle. And then consider doing a pericardial window, which will require surgery or a pericardiectomy. Rarely do that anymore. Generally, you might need to give your patient fluid, but the more fluid you give them, the more they're going to tamponade the heart. So you've got to be really aware of that. So for nurses, you're going to monitor output from the chest tube. When that output goes down, rapidly goes down, you're going to consider that the patient has a cardiac tamponade. If that chest tube drainage rapidly goes up, your patient's got a hemothorax. So volume in the chest tube down, cardiac tamponade, volume in the chest tube up, hemothorax. Okay. Both of which can tamponade the heart, but for different reasons. Okay. And then we're going to monitor labs. We're going to monitor vital signs. We're going to continue hemodynamic monitoring. All right. It's 5 minutes to 10. Probably know that I still have a lot more to talk about. So I do want to just talk really quickly about the aortic aneurysm, because that always is a question. And there's a lot of different sites for aortic aneurysm. So very important just to know that the ascending is the one that is really, really worrisome, followed by the aortic arch, because they're really close to the heart, right? So an ascending aortic aneurysm is going to interrupt coronary perfusion. That's one of our biggest concerns about an ascending aneurysm. In the aortic arch, it could actually interrupt cerebral blood flow. Okay, so we're very concerned about that. And then as it descends, the organs that are distal to that are going to be affected. And that, of course, is quite important. So we really think about what's most important here is identifying the pain. The pain is typically either abdominal or back pain. It's continuous. It may be described as a sharp stabbing pain front to back, or a dull continuous pain. So appreciate those identifiers in terms of aneurysm. But if we are looking at a person who dissects, because that's really the questions, that's the questions that will be asked, will be about a dissecting aneurysm. Okay. And that dissecting aneurysm means that you're dissecting between the intimal wall and the external wall, and you're bleeding into that area. And now that is traveling along the wall because the blood is occupying so much space. You are now dissecting that aneurysm. Your patient initially will have intense, severe tearing pain, and it's constant, either in the chest, which is typically the ascending arch, and the proximal thoracic descending, or in the abdomen, which is typically the abdominal aneurysm. And they typically, at first pass, have severe hypertension. They oftentimes, especially remember, if it's ascending aortic arch, not if it's thoracic or thoracic abdominal, but ascending or aortic arch, they're going to have acute neurologic deficit. It's going to be an acute change in their mental status. Okay. And if this is thoracic, not abdominal, but thoracic, what you will see is pulse differences between the arms. blood pressure differences between the arms. So that's one of the first things that we do when we suspect that you have a dissecting aneurysm, and we suspect, based on the pain location, we suspect that it's thoracic. We're going to look at your blood pressure and your pulses bilaterally, and those are going to be disequal. And that just depends on where the aneurysm dissection is. Okay, so here's the thing. If you're dissecting, obviously we want to protect that. Hang one second. So if your aneurysm is typically 5.5 to 6 centimeters or greater, you're gonna have surgery. Because of incredible stimulation of catecholamines. So you don't become acutely hypovolemic. You become acutely hypoperfused, stimulate the catecholamines through the sympathetic nervous system. You initially will be hypertensive. Okay. And our goal is to control your hypertension. Okay. So first of all, we want to control the pain. And secondly, we're going to put you on an alpha blocker, because we need for your blood pressure to come down, because the higher your blood pressure is, the further your dissection is going to go, right? The higher your pressure, the more you're going to dissect. And that's going to be in the initial presentation. Okay. All right. So going to vasodilate you. Got to get that blood pressure down. Okay. Going to give you some IV fluids, maybe oxygen if you need it. Going to monitor as nurses. We're going to monitor your urine output, your mental status, your vital signs. If you become acutely hypotensive, then we think you've ruptured, correct? And now you've got free blood everywhere, right? So hypotension with the dissecting aneurysm typically means that you've ruptured, right? So your MAP might be 110, 120, 130. I'm dropping your MAP through vasodilation. I'm not making you hypotensive. I'm just dropping your MAP to reduce the amount of volume that is actually perfused into that dissecting sac. But I've got you right around 80 to 90, maybe you're at 86, and then your alarm goes off. I go in your room and your MAP is 55. The likelihood is you have ruptured. Once you've ruptured, don't have much time, because you're going to bleed to death. Okay. All right. So typically when we do surgical management, again, just for informational sake, just to know that a graft is going to be placed inside that aneurysm to close the leak and actually to protect you. Okay. You can go to endovascular. You can have stent grafting. You could go to endovascular lab and have a stent placed, either not in ascending, but only in the descending aneurysms. You're not going to do that in an ascending aneurysm. Lots of complications. Okay. So if it's surgical, number one is the possibility of an MI. Number two is bleeding, which is really common. Number three, because we cross-clamped you, will be renal failure. Number four, limb ischemia, because you were cross-clamped. Okay. So you can have limb ischemia, and you can have colon ischemia also, again, because of cross-clamp. So just remember, if you go to the OR to manage an aneurysm, the things we are going to look for as nurses post-operatively: MI, bleeding, anything that tells you that you have limited blood flow that is distal to the cross clamp. You need to know where the cross clamp was. You need to know where the aneurysm was that's being repaired, so that you can predict what happens. With intervention, remember that's only for descending aneurysms. Because they're descending, you're looking at the blood flow to the organs that are supplied from the abdominal vessel, the abdominal aorta. That'll be the kidney and the bowel and lower extremities. Okay, so just be thinking about that. Remember that intervention is only going to be for the abdominals, and the descending surgery typically is going to be for ascending, arch, and possibly for descending, but not likely, because we'd rather you go to the interventional lab than the OR. Okay. All right. I'm going to end here. There are still many things to talk about. You might notice that at the very end of our CCRN, there is an extra day. That's everything that hasn't been covered. So that means what I haven't covered, what other people don't cover. I'll make sure that you get in that very last day. So next time we're together, we'll talk about peripheral vascular disease, and we'll talk about dysrhythmia and pacing. And the only dysrhythmias that I'm going to talk about are heart blocks and the correlation to pacing. So very good. Thank you very much. Thank you for joining today. Happy to answer any questions, but I am closing class at 2 minutes after 10. And we shall see you next week at 8 a.m. in the Steiner Auditorium. Please make an effort to come live. And of course, you can monitor this, review it. And I said, whoops, I need to remember to record. And then I wasn't.
Thank you, Barbara.
Hi.
Thank you.
Sorry. Yes. Hi. Do you have a question? Oh, you're welcome.